Welcome to today's HealthLine webinar from the American Association of Kidney Patients, titled Phosphorus Lowering Therapies: Why Patient Care Choice and Access Matter. My name is Jerome Bailey, and I am AAKP's Director of Patient Engagement and Advocacy. I'm pleased to host today's webinar, supported by an educational donation from Ardelyx. As the oldest and largest patient-led kidney patient organization in the U.S., AAKP is proud to host this educational webinar as a service to the expanding national and global communities of patient consumers and their families, medical practitioners, researchers, and policymakers who are following research and advancements in kidney care and treatment. AAKP is an aggressive supporter of innovations to disrupt the status quo kidney care. AAKP's HealthLine and HealthLine Innovator webinars fall under our Center for Patient Research and Education. We believe patient and care-partnered education is an integral part of an individual's treatment, and to that end, AAKP is a champion for full patient care choice, the protection of the patient-doctor relationship, and the elimination of artificial barriers and government determinants of health that impede patient care choice and access to FDA-approved treatment options. At AAKP, we work to ensure that patients have a central role in the research and innovation process so that unmet needs are identified and unique patient insights and lived experiences fully inform the research and product development lifecycle. This includes clinical trials to regulatory action and payment decisions. The field of kidney disease innovation has experienced remarkable progress in recent years, bringing new hope for the development of treatments that address the chronic nature of this illness and its related conditions. As researchers continue to expand the horizon of medical science, the future of kidney disease treatment looks promising. With advancements driven by personalized medicine, cutting-edge technologies, and new drugs and devices, and diagnostics that address the needs of patients. The potential to improve outcomes for individuals with kidney disease is vast. Today, we are excited to present a program that addresses a long-standing unmet need in the patient community: high phosphorus levels, also known as hyperphosphatemia. This issue affects over 700,000 individuals in the US living with end-stage kidney disease and involves an imbalance of electrolytes, specifically an excess of phosphate in the blood. While dialysis can be effective at managing many electrolyte levels, it often falls short in reducing phosphate to a healthy level. As a result, approximately 80% of dialysis patients require additional therapy to lower their phosphate levels alongside adhering to a modified low phosphorus diet. To kick off today's program, I would like to introduce AAKP's Chair of Policy and Global Affairs, Paul Conway. Paul is a passionate advocate for patient-centered care, patients participating in healthcare decisions, and the use of patient insights in kidney research. As a kidney disease patient himself for 46 years and a 27-year transplant recipient, he has been recognized for his advocacy work with several national awards. Paul has served in 4 U.S. presidential administrations, including as the Chief of Staff of the U.S. Department of Labor. He has served on multiple federal and nonprofit committees and boards related to kidney health, including as chair of the FDA's Patient Engagement Advisory Committee and the American Board of Internal Medicine Nephrology Specialty Board. In preparation for today's webinar, AAKP conducted an independent flash survey through our Center for Patient Research and Education to understand how patients are managing their phosphorus level and to gauge how high phosphorus levels affect kidney patients' quality of life. Paul joins us to share some of the results of the survey. So Paul, I turn the program over to you.
Thank you very much, Jerome, and thank you for all the work that went in today's production. It's a tremendous issue and one of great importance to everyone. And Jerome and the team at AAKP did a lot of work, and you, as our patient community, did a lot of work informing fellow patients to be in attendance today. So let's go ahead and take a first look at our slides here, which is how people currently manage their high serum phosphorus or phosphatemia. And you can see here that dietary restrictions, pretty standard, 88%, phosphate binders, 61%, managing it through dialysis, 34%, and the use of phosphate blocker, about 9%. The questions that we had in this survey kind of set the stage for the discussion, but they also set the stage for why we're so intense about some of the policy issues surrounding access to new therapies. On this question, we asked a question that patients know quite well, which is that some medical professionals and some researchers are unfamiliar with the term pill burden associated with this condition. And we believe at AAKP it's important to educate non-patients about the number of phosphate binders that patients take to manage their condition. So we asked, how many do you take? This is an interesting one because less than half took 1 to 5 pills, but you can see more than half of your patients take 6 to 10 pills. And we think that if we had run this survey longer, you would see these numbers even higher in terms of the daily intake of pills just to manage the condition. This is important because a lot of professionals don't understand the daily regimen that patients have to go through of taking phosphate binders. That's what we call the pill burden. And so then we asked the question in regard to phosphate binders, the side effects. And only about less than a third indicated that they never had side effects, but 24% indicated that they do usually, sometimes 20%, always 16%, and rarely 12%. So the most important finding on this survey question is that the majority of your patients clearly go through side effects from current therapy or status quo therapy of phosphate binders. And then we asked what types of effects do they experience with current phosphate binder treatment. Gastrointestinal issues, well over half at 62%. That could be nausea, constipation, diarrhea. Fatigue, more than a third experience that. And then other types of conditions, or what we sometimes as fellow patients call the funkiness that goes with this, about 30%. 4% reported headaches. And these are important because these are examples of patient lived experience and patient reported outcomes that people experience. And so then we asked the question to those who are participating, what were the improvements that they would like to see in the management of this condition? This becomes very interesting to AAKP in terms of advocacy for change and for new therapies. Patients want more effective medications with less pill burden. They want lower cost medications and treatments. They want those that are more effective with fewer side effects. They want easier dietary management options so they can get through the day with 3 meals and not feel like they're living their life around dialysis. Those 4 indications are all over 50%. Better patient education came in close to 50% at 45%. New technologies, such as apps or devices to help in the management of it, improved access to healthcare providers, and other. Probably the most important thing on this slide is the desire by patients for innovation that helps them manage their burdens more effectively and really kind of get on with living life. So we asked patients in terms of their awareness of medications to help lower phosphorus other than those that you're taking now. So essentially this question says, beyond the status quo that you're familiar with and the therapy that you're basically assigned, do you have any general awareness of anything beyond that? Less than a quarter said yes. Overwhelmingly, 3/4 said no. And that's a patient education and provider education opportunity for us as we view it. And then we asked this question. In 2023, FDA had approved a new class of phosphate lowering drugs. And the drugs give kidney patients another option to help manage their phosphorus level. And then as a matter of patient care choice, do you agree that physicians and patients should have access to these new drugs if they would improve patient health and decrease the burdens associated with older types of treatments? 88% said yes, overwhelmingly and resoundingly. Uncertain, probably because folks just may not be able to understand what some of their options are or even envision them, 12%. But the key thing here is overwhelmingly patients want change and they want access. This slide is very important for folks to focus on. So CMS, the Centers for Medicare and Medicaid Assistance, is working to take these new drugs, these new innovations, and put them into the kidney payment system, or what is commonly referred to as the bundle, the payment bundle. And it would limit the access that patients and physicians have to these medications if they're put into the bundle. And so we asked this question, which is, do you think FDA, which is in the business of approving new innovative therapies for kidney patients and is highly responsive to the kidney patient community, and we know that perfectly well at AAKP, do you think FDA and CMS should work together more intelligently to make certain new innovations for hyperphosphatemia are both approved and accessible to patients? And 91% said yes. So this was the question to probe folks on alignment of FDA and CMS. The most important thing for you to understand is this. Patients have long demanded change for managing phosphorus, and through activism and through private sector investments in leadership in science and research, there are now new innovations accessible for some patients, but not for all. The limits on those medications in terms of access and patient choice may be increased if those drugs are included into the payment bundle of CMS. CMS has stated that they are going to do that. And what you'll hear at the end of this session from Jerome is a very strong call to action that AAKP has to contact Congress and to tell Congress, tell CMS not to do it. The House of Representatives has done that. Now we're asking for the Senate to do it. And with that, let me go ahead and turn it over to Dr. Barry Smith. Dr. Smith is a member of the board of directors of AAKP. He's a longtime friend. He has past service at NIH. He was the president of the Rogerson Institute. He is a longtime patient champion and somebody that we count on at AAKP to break down issues in terms that people understand so that they can take action and make an impact to make certain all patients have access and choice, including you. Dr. Smith, why don't you go right ahead? It's great to see you today.
Thank you very much, Paul, and I'm delighted to have this opportunity. This is an incredibly important subject, and I would like to see if we can the first slide, and we'll begin with that. Can we have that? All right, phospho-lowering treatments. We've heard that's for the subject for today, and I've emphasized in the second line here something that I think is extremely important. For people, we're not talking about patients. After all, in a way, we're all patients and we're all people. And we want to make people's lives easier and better, both from the medical point of view, but just also from the quality of life. Phosphate is an incredibly important thing. It's an electrolyte in the body. It's part of the genetic code. It has to do with cell structure, part of the cell membrane. It has part of the system for energy to run everything, adenosine triphosphate. It involves our bones and our teeth and our acid-base regulation. It buffers the urine so that the degree of acidity of the urine is normal. So it's a key to so many things in the body, and that's what we emphasize here. Now, you can see on the left on this slide a picture of phosphate. It has phosphorus, which is a mineral, number 15 on the atomic element chart, but that isn't so important. But surrounded by those oxygen molecules, very important. It's why it fills so many functions in the body. On the right side is just a view of that, but the one on the left is the one I think to remember. We all have normal phosphate levels. Interesting here, and the adult levels you can see for most of us, 3 to 4.5 milligrams per deciliter. The details are not so important. But look at the newborn child who's forming new tissues and new bones, 4.3 to 9.3, almost double what we are as adults. So this is a very important element. It's not an element of the electrolyte, phosphorus and oxygen, phosphate in the body. Now, you can talk about normal levels, but there are two things that can go wrong with normal levels. You can have hypophosphatemia, that is too low levels of phosphate, and we see that in certain conditions where there isn't good phosphate intake, but we're excreting a lot of it, putting a lot of it out. Diabetic ketoacidosis, alcohol use disorder, severe burns and sepsis, Cushing syndrome. But then we also have hyperphosphatemia, and that's really the problem we're concerned about, as you've already heard, in kidney disease. Now, here's where we have more intake, but because our kidneys are not working, we're not getting rid of the phosphate that we should. So this is a very important part. And what we see are symptoms of this, limited symptoms that include cramping and calcium deposits in our blood vessels, our heart, lung, eyes. These lead to stroke. And then we also have heart attacks that can be associated with this. So this is very, very important. The regulation of phosphate, again, emphasizing what our kidney does. Our kidney is central to this complex process that involves endocrine or hormonal feedback among multiple body tissues, including bone, our kidneys, of course, and the intestine. And you can see in the bottom right here in stage 5 end-stage renal disease, the kidney has been damaged and it's no longer able to remove the phosphate as a normal kidney would. So now we have the problem, as we said before, of more intake and not ability to excrete. So we need some help with that. One thing we can do, and as Paul Conway already mentioned, we can restrict our diet. And I don't think we stop to think about very often about some of the elements of our diet that contribute a great deal of phosphorus to us. Dairy products are a prime source of phosphate. Soft drinks and sodas, processed meats, fast foods, snack foods, nuts, whole grains, beans, and lentils. So if we restrict our intake, we can help some with the levels of phosphate in our blood, since our kidneys are not doing their removal job properly. And so that's where we begin to use dialysis, as we show here, and that can remove some. But then, as you also see, that as many as half of the patients who have end-stage kidney disease have to take binders to remove that excess phosphate that causes so many problems, including that damage to our heart and blood vessels, which is not something any of us want to have. What we can do to lower phosphate levels? Well, the standard treatment has been phosphate binders. What they do is take phosphate that is now in the intestines, it's in our diet, and like a sponge, you might say, they bind that phosphate and take it up so that it is removed by the intestines in the feces, the normal waste product that we produce. And you can see from the list here that there are a number of things that are phosphate binders, these sponges that we were talking about. Calcium carbonate, calcium acetate. Calcium carbonate, you think of as TUM, something very simple. Lanthanum carbonate, sevelamer, sucroferric oxyhydride. So there are a number of candidates, and they can do the job for us, but there are problems associated with some of these. Putting excess calcium in your body is not a good thing in the long term, because you end up with calcium deposits in your blood vessels, and that again causes blockage of those vessels, and we know that's something you don't want to have. And you can do it with a polymeric binding, and that's sevelamer, but there again, the binding is limited. You can do it with sucroferric oxyhydride. That can stain your teeth, produce acidosis. It makes your stool darker, has a variety, diarrhea as a problem. We know that they can work as a sponge. So if you need to take more of these pills or powders, depending on how they're supplied, you can do that. But that gets us back to this problem of the pill burden, Because if you have a lot of pills to take, that becomes an issue of quality of life. And let's think a little bit more about that. So, pill burden, you've already heard Paul Conway talk about what pill burden is. It's basically how many pills do you have to take a day and how many is too many. And as he said, typical for end-stage renal disease patients on renal replacement therapy, as you can see at the bottom of the slide here, there may be 10 different meds per day, more than 25 pills, and 20 or 24 of these may be phosphate binders. And that's not so easy to take, and whether it's with meals or separately in the morning, in the evening, that is a very real burden, and it's very much a part of the daily life of an individual. So, can we do something about that? Are there alternatives to reducing phosphate? Now, we had that list, and that was impressive. Several things are available, but there are problems associated with all those blocking or binding agents, I should say. And we need to have some other way of dealing. And so, what has come along, and I think is very important, is this drug from Ardelyx, Xphozah, a new non-binding way of blocking the entrance of phosphate to the body. Let's see how that works. There's a different concept here, and this is important to understand. Now, normally, how does phosphate get from the intestine? Because now we've eaten some dairy products, we have phosphate in the intestine. It gets into our bloodstream through pores between the cells in our intestines. And you can see that here in the center of the slide. The phosphate goes from the center of the intestine actually down this hole into the blood. Now, if we block that pathway, we can stop phosphate from being absorbed into the blood. And so now we have not a phosphate binder, we have a drug called phosphate absorption inhibitor. And that's very important because it gives us as physicians and as people who have kidney disease an option to consider that may be better than some of the others. It's not necessarily better, but for some of us it's better. It may be important to have that option to take. So let's see how that works. It acts on a sodium ion exchanger, which is shown in the center of the slide, and you see Xphozah acting on this. And what that does by acting there, it causes these pores to be closed. There is a protein called claudin, which when it comes together closes off the pore. And now what happens is that the phosphate cannot get into the bloodstream. So that's a very important way of regulating the phosphate. And what happens to that excess phosphate that can't get into the bloodstream is it's eliminated in the feces, in the waste products that we produce. So now, instead of talking about many pills, with this new phosphate absorption inhibitor, we're talking about one pill twice a day. So that set of sponges in the lower left there of the slide, we don't have to worry about that anymore. We don't need more sponges. So we've done an important thing to make controlling phosphorus easy for us as individuals who have kidney disease. So that's the point. We now have a new option. We have a new tool that we as physicians and as patients and as people can use to control the phosphate levels in our blood. That pathway, again, as we said, has been blocked, and phosphate simply cannot get into our bloodstream. So as I've said, and I want to emphasize, what we have is a new tool in our physician toolbox for lowering phosphate in chronic, very late stage and end stage kidney disease. And having that ability of choice is very important. It's important for the patient and it's important for the physician, because if someone is not tolerating one of the phosphate binding agents, for example, or is apt to be developing calcium blockages in the blood vessels, now we have another way to attack the problem, and we're reducing it, getting rid of that pill burden that we had. This is a big win for people with kidney disease. And I use the word people again because what we're doing is providing choice. Unfortunately, there's a problem because when we get to the real world, and again, Paul mentioned this in the survey, when a new drug comes along, Medicare looks to see if it can cut costs. So although it will pay for it for an initial period, the transitional drug approval period, then ultimately that new drug is not a choice anymore because the amount of money that is allowed for the treatment of an individual with kidney disease is fixed. So that if a new drug is added into that, it is going to have to fit into that fixed cost. And what that means is the patient's choice and the physician's choice becomes limited. And this is where AAKP, with the patient voice and the patient choice, is so important. And also Ardelyx, the developer of Xphozah, is so important to make a case for maintaining this as a choice for all of us to have, physicians, again, and people who have chronic kidney disease. Final point, and this is a plea from a physician. The general principle is that, as I see it, including new drug development entities or classes such as phosphate absorption inhibitors versus binders, automatically or via TDAPA, as CMS is doing, putting it into the end-stage renal disease bundle is wrong. It is wrong both medically because we're talking about a different mechanism achieving a different end therapeutic result. CMS likes to talk about functional classes, but that's not right. This is a different mechanism achieving a different end therapeutic result. It's also wrong because this approach to the funding of the payment for renal disease stifles research and development for new and different therapeutic approaches that may be of yet greater benefit to patients. It's one thing to say, well, we have 5 binders at least, but if they're not working, it's not a choice for patients. And we're limiting that choice and we're limiting the quality of life that they can have. So we can't let this happen. We need that voice, strong voice out there to be sure that the access is maintained to these new therapeutic entities. Thank you. And I'll turn it over to Jerome again to move on.
Thank you for that great presentation, Dr. Smith. We appreciate you sharing information on how abnormal phosphorus levels can impact the body. Our next speaker is Dr. Laura Williams. Dr. Williams is the Chief Medical Officer at Ardelyx and has extensive experience in pharmaceutical drug development, healthcare policy consulting, and patient advocacy. With over 25 years of experience in various therapeutic areas, she has a proven track record in drug development and leadership in both biotech and large pharma companies. She brings a strategic focus to clinical development programs for the growth and success of private and public companies and their shareholders. It's my pleasure to turn the program over to Dr. Williams.
Thank you, Jerome. First, a huge thank you to AAKP, not only for conducting this webinar, but more importantly, for your extraordinary commitment to and advocacy for patients with kidney disease. We at Ardelyx are both honored and grateful for your partnership. And thank you, Dr. Smith, for your presentation. It's an excellent segue to what I'd like to discuss. So what I'll do first is give a little bit of a brief background, if you will, in terms of just some background information. I'll review why managing phosphate in the body toward a normal range is so important. And then I'll speak to the potentially negative impacts of moving phosphate lowering therapies into the bundle. This slide basically outlines, the fact that social determinants of health, including policy and law, are drivers of health outcomes. And so today, one of the focuses that we want to highlight is how, again, policy and law can have negative implications in terms of health outcomes. So this is a bill slide, and this is the background piece. It just want to highlight the fact that chronic kidney disease is a real problem in the U.S. It affects nearly 37 million Americans. But despite this high prevalence, 9 out of 10 folks, up to 9 out of 10 folks, actually don't even know that they have chronic kidney disease. So that's a problem. And while diabetes and hypertension are the most common causes of chronic kidney disease, there are also genetic predispositions with, APOL mediated kidney disease, and there are other unknown causes. A relatively newer classification, we call this CKD of non-traditional origin, is also something that I think we need to remember. And this is basically involves people who spend a lot of time in very heat-prone working environments. So construction workers, agricultural workers, and basically what happens is there's repeated dehydration that basically ends up damaging the kidneys, and they then have a result in chronic kidney disease. And in this build, if we move forward, what do we do with respect to chronic kidney disease? So again, 37 million patients with or people with chronic kidney disease in the U.S., and approximately 80,000 of them have actually progressed to what we call renal failure or kidney failure or end-stage kidney disease. And they're being treated with what we call renal replacement therapy. And that means dialysis or kidney transplants. So folks whose kidneys have failed and are not working, about 2/3 of them are on maintenance dialysis, and the other third actually are able to be transplanted. And dialysis organizations are really the mainstay of dialysis services. And these services include not only the dialysis treatment itself, but medications that are adjacent to a dialysis session, the labs that, the lab work, the blood work that has to happen when dialysis patients are there, and any supplies, as well as the staff that are taking care of the patient. When we look at, some of the health equity issues, clearly Blacks and non-white Hispanics are disproportionately affected with kidney failure, with a 4-fold and a 2.5-fold higher rate, respectively. Despite that higher, sort of rate of kidney failure, they are less likely to actually get transplanted. 1.6 times and 2.5 times higher rates of transplants happening in whites versus Blacks and non-white Hispanics, respectively. I think this is part of the important piece that we're talking about today. Medicare has been the primary payer for patients with kidney failure in the U.S. Since 1972. And there have been additional incentives and changes to this model over time. Basically, in 2011, Medicare, CMS, said we're going to move from this, fee-for-service system to a fixed payment system. We call it the ESRD, prospective payment system. It's a long name for what has already been described as the bundle. So that was in 2011, and that was mostly driven by a lot of the drugs used to treat anemia in patients who were on dialysis. But I will say that I think that today that's more of an antiquated system, and applying that system to newer drugs now is probably not the best path for patients. I want to talk now about some of the complications around chronic kidney disease, and we are focusing today really on hyperphosphatemia. And again, why do we do that? There are a number of complications that happen, obviously, with patients who are on maintenance dialysis because their kidneys have failed. But if you look at this chart, you can see that hyperphosphatemia carries the greatest risk, more so than elevated calcium or anemia, or even how effective their dialysis service is. Hyperphosphatemia carries with it the highest attributable risk of death of any of those complications. So it is a big deal. This actually highlights, why this is a big deal. So it's a significant medical issue for patients and for all of the clinicians who take care of them. And if we just focus on the graph here, I think it's telling when you look at, the normal range. So the bar graph that is, dark blue at 4.5, 4 to 5, and then you actually go every increment, a milligram increase in the serum phosphorus carries an increased risk of death. And so the higher the serum phosphorus goes, the worse the morbidity and the mortality is. And so it is a big deal, and it is something that obviously we have to constantly take care of, monitor, and try and control. Next depicts, some of the things that happens, when the serum phosphorus levels go up too high. You can see images here of patients who are on dialysis who in one, going from the left to the right, basically have calcium deposits in their blood vessels. This first one on the left is in the aorta, which is the largest blood vessel in the body. And what happened is this elevated phosphorus binds with calcium, crystallizes, and then lays these calcium deposits into the blood vessels. And that blocks blood flow. In the middle, these are blood vessels that surround the heart, so our coronary vessels. And you can see the same sort of, issue here. All of this plaque, all of these, calcium deposits does not bode well, and actually obviously leads to heart attacks and death. And then finally on the right, this is the blood vessel just behind the knee. It's called the popliteal artery. Again, it is lined with calcium phosphorus plaques. That leads to pain in the legs. That leads to potential amputations. All of those things. So this elevated phosphorus is a huge deal. And that is why you will see that we have guidelines that tell us what we need to be doing in terms of controlling and managing phosphorus. And so the KDIGO, Kidney Disease Improving Global Outcomes Committee, has basically said that we should make sure that we try to maintain serum phosphorus levels toward the normal range. And then more broadly, when we look at, international guidelines, again, we're saying the same sort of things. The recommendation is to try and make sure that serum phosphorus levels are well controlled. We've talked about this a little bit. There are a couple of things that we can do in terms of trying to manage serum phosphorus that don't involve drugs, so non-pharmacological treatment approaches. One that you've already heard, Dr. Smith speak about is reducing the dietary phosphorus intake. And while that sounds, you know, easy, you saw from his slides that that phosphorus is ubiquitous. It's everywhere. It's in the good foods, it's in the processed foods, the bad foods. It's everywhere. And for a number of patients who are on dialysis, given the socioeconomic disparities, limited resources, and geographic regions, a lot of those patients live in food deserts or even food swamps. And so saying that you should just reduce the amount of phosphorus that you take is not always practical. You can see that again, the other way, the other non-pharmacologic way to try and remove excess phosphorus is actually dialysis itself. But just think about that. Right now, patients already, those patients who are getting dialyzed in center, go to that dialysis center 3 times a week, and their dialysis sessions are anywhere from 3 to 4 hours per session. So nearly 12 hours a week, patients are, hooked up to these dialysis machines. And so asking to extend the time or the frequency of dialysis, again, is not very practical. And so that brings us to the pharmacological things that can be done. And you've heard already a little bit about the phosphate lowering therapies. Let's dig a little bit deeper. So most patients who are, whose kidneys have failed are on maintenance dialysis. most of them are prescribed phosphate binders. And it wasn't until recently, as you heard, which, in October of last year, prior to that, the only class of phosphate lowering therapy were phosphate binders. And as the name implies, and as you've already heard, how do these drugs work? They bind the phosphate that's in the intestine, and then they excrete it out through the stool. But patients typically have to take 3 tablets with every meal. So when you look at, sort of the median number of pills that, and we're just talking binders that they take, that's about 9 pills a day. And there's a graphic there that just looks at the median daily phosphate binder dose, and you see about 9 pills. And then on the right, it's what that, sort of adds up to in a week's time. I won't linger on it because you've already heard it. The treatment, in terms of these phosphate binders has been just one class, a one mechanism of action of drugs for like 50 years, for 5 decades. It's been phosphate binders. And yeah, they've advanced in terms of, the different types. But at the end of the day, this issue with pill burden, and not just pill burden, there's an issue with, whether or not patients actually are able to get to their normal phosphate levels. Again, I won't belabor it because Dr. Smith has gone through it quite nicely. But this new phosphate lowering therapy, which we discovered, developed, and now have made available to patients, is called Xphozah or tenapanor. It was approved in October of last year. It's the first in class, minimally absorbed, non-systemic, small molecule. We call it a phosphate absorption inhibitor. Some people say phosphate blocker to differentiate it from binders. And the mechanism is, as Dr. Smith already alluded to, basically, again, blocking an antiporter, a protein that sits in that membrane. It blocks NHE3 so that phosphorus doesn't come out of the lumen and get into the bloodstream. So a phosphate blocker, a phosphate absorption inhibitor. It sort of speaks to the difference in pill burden. So Xphozah has been shown to be effective in terms of lowering serum phosphorus with this novel mechanism of action, not binding, but blocking. And for patients who are using phosphate binders, but they still are not able to get their phosphate levels controlled, then you can use Xphozah in combination. You can add Xphozah to that regimen. And for those who can't tolerate phosphate binders, then you can use Xphozah in that setting as well. But it provides a simplified dosing regimen where there are fewer and smaller pills. And that's what's depicted in the picture below. So what we saw in our clinical trials, which led to the approval, was that a large proportion of patients were able to get meaningful reductions in their serum phosphorus. And obviously, you have to weigh that with the safety risk. And when we looked at risk benefit, there was an acceptable safety profile. And we'll talk about that a little bit more going forward. This is the crux of the issue. The impact of the bundle system, or, putting these phosphate lowering therapies into the bundle is problematic. And this sort of, again, speaks to that. And I'm using, one of the examples that CMS often uses when they talk about putting these drugs into the bundle and why this might be a good idea. So again, this movement to a fixed payment system from a fee-for-service started in 2011. And in 2017, CMS modified this bundle system to add what we call a TDAPA period. It's a period, TDAPA means transitional drug add-on payment adjustment. But the big point here is that this is a 2 to 3 year period where before they, actually go into the bundle, CMS collects utilization data for this new drug, and that's what they use to determine how much additional money they're going to add to that fixed payment. So let's say the fixed payment was $250, and after 2 to 3 years of looking at the data, they decide, oh, okay, this is how much we're going to increase it. And so when we talk about a class of drugs, called calcimimetics, this was the first example of CMS using this TDAPA, this additional period to figure out how much additional funds they would add to that fixed payment. And so they use this as an example of, why they think this is a good idea. And there are two calcimimetics that are approved. One is oral, it's Sensipar or Cinacalcet. The other one is injectable, it's IV, it's called Parsabiv or Etacalcetide. And these were the first class of drugs to actually go through that TDAPA period. And when they collected that data, at the end of that resulted in the fixed price going up by $10.09. There are other examples of new drugs, right, that have followed since the calcimimetics. Korsuva, which was a drug or is a drug to treat itching in patients who are on maintenance dialysis. When they did the same sort of TDAPA period and assessment to see how much they would raise the rate, that fixed rate, it was only 40 cents. 40 cents. And we're going to talk about that a little bit more. The bottom line is that the negligible increase in that bundle-based rate for these products really eliminate their use in patients on maintenance dialysis because it doesn't pay for it. So CMS wants to move oral phosphate lowering therapies into the bundle starting on January 1st in 2025. The issue here is that, they initially wanted to do that in 2014, but since then, there have been 3 acts of Congress, so 3 sets of legislation that have said this is not the right thing to do. And so Congress passed those legislations, prevented those drugs from going into the bundle. But again, the last legislation will expire on December 31st unless Congress acts again. This is the whole point. So on June 27th of this year, CMS said, look, we're going to move these drugs into the bundle starting January 1st. And so that would mean that payment for these phosphate lowering therapies would move from Part D, which is where they sit today, D as in dog, to Part B, to the bundle. They have given a lot of credence to doing this based on the example with calcimimetics. But at the end of the day, when you actually look at the data does not support that. The increased use in calcimimetics, they've said, well, when we did that, calcimimetics, utilization was broader and better, and better in all populations. But in fact, that increase in utilization only occurred during the TDAPA. Actually, once the drugs were out of the TDAPA period, the utilization dropped precipitously. So if we use calcimimetics as an example, in the TDAPA period, the use was as high as 10.4%. But once that period was over, the use has now dropped to less than 1%. So people are actually not benefiting from these new improved treatments. And so using that as an example is actually not the right thing to do. These are the issues. We think that moving these drugs, these phosphate lowering therapies into the bundle will actually restrict patient access to these novel treatments. Because again, there's no financial incentive for dialysis providers to actually use these drugs. And the individual patient physician shared decision making goes away. So rather than looking at a patient and saying, your level is X and, it's high, even though I have you on a phosphate binder, I want to try something different. That sort of shared decision making goes away because now there's a protocol that says you can only get this lower cost, cheaper drug. So that is fundamentally the problem. And we think at the end of the day, who does this impact the most? It's patients. legislative efforts to continue excluding these drugs, these phosphate lowering therapies out of the bundle, has gotten broad support across a number of organizations. There is a congressional effort again so another legislation to hopefully delay putting these drugs in there. And there was a bill passed from the House, HR 5074, and from the Senate, 4510, that actually says we again want to block the CMS from putting these drugs into the bundle. And on the right, there's a whole list of organizations, of course, including AAKP, that are in support of keeping these drugs out of the bundle. I will stop there because I know we're close to out of time, but thank you for the opportunity to share this information.
Thank you, Dr. Williams. As you, our audience, just witnessed, Dr. Williams is deeply involved in healthcare policy and patient advocacy. Her work has had meaningful impact on the lives of patients. Dr. Williams, we are so appreciative of you joining us today. It's now my pleasure to welcome Richard Staswick to the program. Richard is a retired professor who has been living with kidney disease since he was 22 years old. Between then and now, he has been on in-center hemodialysis twice for a total of 2 years and received 2 kidney transplants, which lasted a combined 37 years. His second transplant kidney developed a cancerous tumor, which had to be removed in 2022. He is currently on home hemodialysis. During the past 40 years, Richard and his wife were fortunate to have 2 children and deeply fulfilling careers. At present, he is on the Patient Advisory Council for the Kidney Project, a potentially revolutionary development in treating ESRD. Richard is excited about representing AAKP as an ambassador, and he's here to share his story on managing his phosphorus level. Richard, welcome to the program.
Thank you for having me.
So can you tell us a little bit more about your kidney journey? Tell us a little bit about your experience on dialysis.
My experience on dialysis has been pretty negligible. I mean, I don't have any serious problems when I dialyze. I do home hemodialysis now, so I get to control when I do it and how long and how often. So that's been a positive development. So, overall, not bad. I mean, one of the biggest issues, of course, is something we've been talking about today, and that is, controlling my phosphorus levels.
Yeah. How often do you check your phosphorus level?
Monthly. We draw our labs monthly, send those in to be checked, and I get the results usually within 2 or 3 days after I've sent them in.
What did your doctor or your healthcare team tell you about hyperphosphatemia and why it's important to manage your phosphorus level?
Many of the same dangers we've been talking about today, and that is, calcification of the arteries, bone problems with bones and deterioration. And so these are serious issues which can lead to death eventually. So I was well aware of the dangers, and I try to do everything I can to control my phosphorus levels, but it's almost impossible to do with diet alone.
Yeah. Can you tell us about your experience, managing your phosphorus, your experience taking phosphate binders? Was it difficult?
I do take phosphate binders. Right now, I'm on calcium acetate, but I've been on sevelamer and other binders. Generally, they work fairly well, but not enough to keep my phosphorus within normal ranges. So it's been a struggle, and that's part of the reason why we've tried different binders over time. but none of them seem to do the trick in and of themselves.
We did receive a few questions from our audience, the folks who registered to participate in today's webinar, that I would now like to ask our panelists. This first question is for Dr. Williams. Dr. Williams, how would I ask my healthcare team if I'm a candidate or medically eligible to take Xphozah?
Yeah, that's an excellent question. I think it's a really practical one, and it's an easy one. And I think Richard was starting to to it. At the end of the day, as we said before, about 80% of patients who have high phosphorus are on phosphate binders, and yet when you look at their phosphate values over an extended period of time, let's say 6 months, a good number of the 7% are still not controlled. And so if that is you as a patient, if you fall into that category, part of it is now knowing that there are other options, other classes of drug. There's now the phosphate blocker. So I think it's really relatively straightforward. If as Richard said, he sees his phosphate level every month. If you see that it's still not where you and your provider want it to be, you should just suggest, ask, what else can we try? And the information that we tried to provide today is to say that, there are other classes of drugs out there. And to me, this is very similar to what we see in other disease spaces. Hypertension, for example. Rarely are people controlled with one mechanism of action. They're on different, antihypertensives. So it's the same concept. I think, again, you've got a real good value right there in front of you, your phosphorus level. And that can be, sort of the starting point of the conversation, that shared, decision making that happens between the patient and their provider.
Another question for you, Dr. Williams. Can you talk a little more about the side effects of Xphozah?
Yeah, if we look at our package insert and we talk about what happened in our clinical trials, clearly diarrhea is the most common side effect that we saw. I mean, one of the things that I noted is that this was a minimally absorbed drug, and what does that mean? That means that this drug rarely gets into the bloodstream. Very little of it, I should say, gets into the bloodstream. So you don't get a lot of side effects. The most common side effect, the one that we saw in patients that had an incidence that was higher than placebo, was diarrhea. And so one of the things and I will point out that in this patient population, in patients who are on maintenance dialysis, a good number of them, maybe a third, up to a third, actually complain about constipation. And so what we have done and what we've seen in some of our surveys is that for patients who have said they saw an improvement in their phosphate management because they were on Xphozah, a good number of them said that was actually because they saw not only improvements in pill burden, but improvement in their bile habits. So part of it is educating patients to stop taking laxatives, stop taking stool softeners, and that usually helps. I will say that most of the cases of the diarrhea is mild and moderate in intensity. It's usually short-lived and resolves spontaneously or with a decreased dose.
Yeah, and I see that we have Richard back with us. So, Richard, I'm going to ask you this question again. When this new phosphorus treatment became available, Xphozah, how did you and your doctor decide, together that this was the right treatment to try for you?
I had heard about Xphozah, sorry, at a meeting 2 years ago in the summer of AAKP meeting, and sounded like it could be very promising. And so I mentioned it to my doctor, and he actually then did some background research as well. And we decided together that once it was available, because it was a while before it became available and was approved, that we would try it.
And can you talk a little bit about what your experience has been with Xphozah?
Well, at the beginning, I was given a 30 milligram dose. And so that led to my having diarrhea, which was pretty bad. So I stopped using it for a while. And now I have a 20 milligram dose, which has not caused any side effects at all, and it has brought down my phosphorus levels to normal levels, actually. I'm still on binders, so I'm looking to wean myself off binders and just potentially going on Xphozah only.
So, one more question for you. Why is it important that innovation and research in new treatment options continue?
Well, because the options we have right now are not the best, I think, that we can have. They don't control, for example, blood pressure well. They don't control phosphorus. They don't control potassium. So, we need to keep on having new innovations to make the life better for dialysis patients.
This next question is for Dr. Smith, actually. Dr. Smith, what advice would you give dialysis patients considering Xphozah?
Well, I think if you're having trouble lowering your phosphate level and you are on a binder, one particular binder, that adding Xphozah to that would be worth a trial. And I think working with the patient, you say, well, let's see how putting these things together will work and whether we can achieve our goal of getting the phosphate level in the normal range. So I think that's the way we would approach it, working together to solve the problem.
Thank you, Dr. Smith. And I'm going to go to our last question, and I'll pose it to Richard. In your opinion, why is it critical that kidney patients and the doctors that they choose to care for them have choice and access to all FDA-approved treatments?
Well, my experience has been in talking to other patients as well that there isn't a one size fits all solution to some of the problems that we experience as patients. So having a wide range of different options is vitally important, because what may work for one patient may not work for another, and it's best to be able to have those options so you may be able to find one that works for you.
So I want to thank all of our speakers again for being with us today. We appreciate your insights and dedication to improving the quality of life of kidney patients. If anyone watching has additional questions for our speakers or about today's webinar that we were unable to get to, please email us at info@aakp.org, noting the webinar title in the email subject line. Are you currently prescribed Xphozah and passionate about advocating for patient choice and access to treatment? If so, we want to hear from you. Please reach out to AAKP at research@aakp.org to share your story and make your voice heard. Also, if you believe that all kidney patients should have choice and access to FDA-approved treatments such as Xphozah, let your legislative and congressional representatives know. Visit the AAKP Action Center, and with a click of a button, you can contact your senators and encourage them to support the Kidney Patient Act, which ensures patients have choice and access to oral therapies like Xphozah. Let's work together to ensure all patients have the option they need for their health and well-being. In closing, AAKP is thrilled to acknowledge National Phosphorus Awareness Day every April 5th by offering important education on the harmful effects of high phosphorus levels in individuals with advanced chronic kidney disease. As we learned on today's webinar, high phosphorus levels can lead to serious complications such as bone and heart problems, making it essential for patients to be aware of their phosphorus intake. By raising awareness on National Phosphorus Awareness Day, AAKP hopes to empower individuals to take control of their health and make informed decisions about their diet and treatment options. Together, we can work towards improving the quality of life for those living with chronic kidney disease. If you are not already a member of AAKP, we encourage you to join. AAKP offers free memberships to patients and their family members, as well as living kidney donors. To become a free member, join online at aakp.org/join or by phone at 1-800-749-2257. To receive all the benefits of membership, please be sure to include your email address when signing up. As an AAKP member, you will be notified about all of AAKP's upcoming events, the latest in our educational program series, and when opportunities arise where your opinions and experiences are needed to help inform innovation, advance care, and make a meaningful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the independent patient voice and change status quo kidney care. You will also receive a digital subscription to our bi-monthly magazine, AAKP Renal Life, and can select to receive any of our 5 different electronic newsletters, all for just signing up. We also invite you to check out our blog to read some great articles and patient profile stories, and follow us on social media for all the latest news and to keep up on what's trending. AAKP is dedicated to helping kidney patients across the disease spectrum understand their condition and take control of their health care. We are proud to offer a variety of resources for both patients and care partners. By visiting our website at aakp.org and clicking on the AAKP Store button at the top of the homepage, you can find a variety of educational brochures and online tools to order or download free of charge, including titles such as Understanding the Food Nutrition Fact Labels booklet or the Coping, Living, and Thriving with Kidney Disease brochure. You can also order materials by phone. AAKP has more exciting events planned for the rest of 2024, including our AAKP 49th Annual National Patient Meeting taking place September 25th through the 27th at the Rosen Plaza Hotel in Orlando, Florida. This year marks our return to an in-person event for those comfortable participating in an in-person meeting, while also offering an interactive experience for those tuning in virtually. The National Patient Meeting is the largest kidney patient conference in the U.S. with a growing international audience, features a diverse lineup of speakers crossing all sectors of the kidney community. An exhibit hall allowing participants to engage with various kidney-related companies and organizations and various other networking activities. And our 7th Annual Policy Summit is scheduled to take place November 20th at the National Press Club in Washington, D.C., and will also allow for virtual participation. Registration for both events is now open. And finally, you can also visit our YouTube channel to watch a number of great presentations and webinars, all available on demand from our 2023 events and programs, as well as 2024 programs as they occur. Once again, we'd like to thank Ardelyx for supporting today's HealthLine webinar, and thank you Dr. Barry Smith, Dr. Laura Williams, Richard Staswick, and Paul Conway. To our audience, thank you for joining us today. Have a wonderful rest of your day.